So with that, I think we're going to move on to answering some of your questions. We have some questions that came ahead of time, and we can start with those, and then you're welcome to answer your questions online, and we can see them here on the screen and ask them for you. I'm going to start with one that from Debbie. I was diagnosed with stage 1 breast cancer in April and have just finished radiation, and I'm currently taking Arimidex, but have started having severe pain and tingling in my hands and fingers. Are there any suggestions for relieving it? So Arimidex is one of the hormonal therapies. It blocks the conversion of estrogen, of the precursors of estrogen, into estrogen. So we used to think that the ovaries stop making anything after menopause, but they still do. They make the precursors of hormones and a little bit of estrogen, and then the estrogen is made in the organs themselves, in the bone, in the brains, in the breast, in the muscles. And what the aromatase inhibitors do is block that. So you really don't have estrogen, pretty much, you have very little estrogen anywhere in your body. And that causes a lot of side effects, including joint pain and these pins and needles that you're talking about. There are 3 different flavors of aromatase inhibitors, and so sometimes changing from one to another will help with these symptoms. Another is that tamoxifen, which is a different mechanism. It's not doesn't stop all the hormones in your body. It blocks the estrogen from getting into the cancer cell. Sometimes that works pretty well, almost as well as the aromatase inhibitors. It's about 1 or 2% different and has a different set of side effects. So if these are making you crazy, you could also switch to that. And that brings me to one other question here about what is the somebody who had breast cancer and was on tamoxifen and or is asking what the current treatment is between tamoxifen and the aromatase inhibitors. Do you take one for 5 years and then one for 2, one for 3? And the answer is that's still being worked out, what the best is. If you're a drug company that makes one, you say you should take this one. If your drug company says the other, you should take that one. We do know that you need hormonal treatments, but we exactly the right match is not, we don't have a perfect match. So taking something for 5 years is important. There is some suggestion that switching off may work better than not switching off, but not to a huge extent that it's worth suffering if you have a lot of side effects just to be able to do that. 5 years of something is more important than nothing. I'm going to, now we have a bunch of questions about screening that came ahead of time that I'm going to answer, and then we'll move on to some of the ones that you're asking. One is somebody who had wait a minute, where is it? Here it is. Conflicting reports about annual mammograms and pap smears. This is a woman who's over 60. Over 60, if you've had 3 normal pap smears and you're monogamous and your partner's monogamous, you can do them every 3 years. In terms of mammograms, again, if you've had all normal mammograms, then you can actually do them every couple of years after 60. And one of the interesting new things, and somebody else mentions this in another question, is we're finding out that how dense your breast is on mammogram makes a difference in your risk for breast cancer. So not just that it's hard to see, but that you're at higher risk. The density on the mammogram may be a reflection of the neighborhood. It probably not the cells so much, but hormones make it more dense. If you stop hormones, they get less dense. And so if you have a very dense mammogram, then you need to have your mammograms more frequently. Or if you're young, you might have ultrasound or MRI instead of a mammogram, particularly if you're high risk. So some women have used ultrasound, and one had a good experience, one had a not good experience in our questions. Ultrasounds are, the bad thing about ultrasound is it depends on who's holding the transducer and how they hold it. I mean, if they look up at the wrong time, they could miss your lump entirely. So it's harder to get the whole breast on an ultrasound, and therefore it's harder to do screening. There are people working on whole breast ultrasound, which will be a lot better. But depending on who you're going to, if they're comfortable doing ultrasound screening, that can be an adjunct to dense mammograms. MRIs, the problem is that they're too sensitive. They find everything, and most of what they find is benign. So, but they're not radiation. So if you have a dense mammogram and you're high risk, you carry the gene, you had breast cancer in one breast, then MRIs might be a reasonable option for you, maybe even instead of mammograms if you have dense mammograms and you're under 50.
We might also talk generally about how we think about risk and appreciate risk. I think one of the things I remember as something that many people are surprised to hear is that many women get diagnosed with breast cancer and have no breast cancer in the family.
Right.
In fact, it's probably the case that those of us that have breast cancer in the family, we probably overestimate our risk of getting it. And actually those, in those cases where we don't, we probably underestimate it, which again highlights why exercise, all those things that you talked about earlier, are important for everyone.
Yeah.
And that we need to learn and be empowered to learn these facts.
Yeah. No, absolutely right. Only 5 to 10% of breast cancer is hereditary or genetic, where we know we can detect the gene. So we really have to be careful. And there's an interesting question here from one of you asking about your 26-year-old, your young kids, and that you had atypical hyperplasia. What should they do? Well, first of all, atypical hyperplasia is not breast cancer. Most people with atypical hyperplasia never get breast cancer. And if you haven't gotten it in 10 years after being diagnosed with ADH, as we call it, then you're not going to get it. So in the first thing, you're not that much at risk. And I wouldn't do anything that exciting to your 26-year-old and 29-year-old daughters except for get them exercising and watch their weight so they don't gain too much weight, but really live a healthy lifestyle and be aware. I mean, the big thing with young women is not so much that they should be getting screening, because most of the cancers in young women don't show up on a mammogram, a lot of them. But the big thing is, if you feel something or if you have anything that's abnormal, get it checked out. And if your doctor poo-poos it and says, oh, I don't think it's anything, go see another doctor. Mm-hmm. Because the big thing you hear from young women who are diagnosed with breast cancer is that they felt it. They noticed it, and the doctor poo-pooed it. And what we really have to do is force the doctors to pay attention. Nowadays, it's very easy to biopsy a lump with a core biopsy. You don't even have to have surgery. And if you feel something that doesn't feel right to you, you need to get it checked out. So now here's a question, Steve, that's right up your alley. My mom was recently diagnosed, and part of her recommended treatment was Herceptin. This is the treatment for women who have too much HER2/neu. I know Dr. Love spoke a few years ago about a shorter course. There were some studies looking at 9 weeks as opposed to 12 months of Herceptin, and she wonders, if there's any more research about that. Do you know of any other research? Have they really documented that the shorter course works?
This is a topic of ongoing studies. At this point, most physicians, based on the evidence, would still recommend a year of therapy. But I would say let's continue to follow research. This is, again, I think all the things that Sue and you and I talked about today came because we funded we funded translational research, work that looks not only at the underlying biology and what's going on at a cellular or molecular level, but also studies and learns, does this really matter? How do I actually use this in clinical practice? This concept of actually taking these observations and in fact getting sufficient evidence to know that it should change what we do.
Right.
That must be very frustrating, I think, actually, to many of us, because we see in the newspapers all the time about single studies or single observations.
Usually in mice or rats.
And now with new tests and biomarkers, often there are hundreds of studies that might say, why don't we look at this or look at that. I think that with Oncotype DX, with the new generation of work that is now going on, I think we as a community are recognizing we need to do high quality studies and gain evidence in clinical practice in order to justify, again,
Right.
these new tests for decision making.
And this is exactly what we're trying to do with the Army of Women, because the researchers say to me, oh, well, I don't know how to find women. And so we say, well, we'll do that part. We'll find the women. But we as women then have to be willing to be on this. I have another question for you. This sort of relates to the Oncotype. I'm surprised your slide showed no tamoxifen for ER-positive, HER2-negative, high-risk cancer. Go ahead.
Yeah, so they actually, again, for ER-positive, HER2-negative cancer, they should also be offered tamoxifen.
Even if they're high recurrence rate.
Even if they're high recurrence score.
Even though you haven't shown that it does much.
What I do say is we can't. What I say is we can't count on a large benefit from hormonal therapy,
right.
But we haven't done, I guess, the studies that actually show that hormonal therapy should be withheld in that setting.
Okay, so if you're having a lot of problem with it, it's more iffy, is what we're saying. And then the other thing that often happens if you're premenopausal, certainly, and ER positive and high recurrence, is that the chemo puts you into menopause, which is a hormone therapy in and of itself. And so then it may be that adding tamoxifen to that doesn't really add much.
But all this is highlighting that again, not all the breast cancers are the same. There's an underlying biology which we can now reveal with quality standardized testing. And it's really important to be informed. In fact, the conversations at the time of diagnosis with your physician, what do we know? Is there more that we can know? That's so critical.
But as a physician, I would also say, sometimes you have to ask the physician, well, what about this test I heard, you can do about hormones or not, why can't I have that? And sometimes the physicians are like, oh yeah, because they're busy and sometimes you keep up on it even more. So it's important to make sure that women know at the time they need to know it, that they have these options. Here's a good question that I have a nipple that tends to invert, and it started around menopause, and she's had an MRI and a lumpectomy and some atypical hyperplasia. Should be concerned about the nipple. Generally speaking, if you haven't had inverted nipples and they start to invert, you should get it checked out, but you've certainly gotten it checked out. So with an MRI and a lumpectomy, no, you had the lumpectomy in the other breast. I would watch it, repeat. Sometimes they have trouble seeing right behind the nipple with an MRI or a mammogram, and if there's any question, they could certainly do a needle biopsy. Maybe not a core, because you don't want to have it go through your nipple, but you could stick a needle with a little Novocaine and see if you could get some cells to look and see if there's anything abnormal. It's probably okay, but any change needs to be checked out. So another question about, is it unusual that 3 women in a family have 3 different types of breast cancer? No. We don't know what causes breast cancer. We don't know why. And sometimes it's hereditary. The people who carry the gene for breast cancer, BRCA1 or 2, or certainly BRCA1, tend to have triple negative breast cancers. But very often it's because you're exposed to different things. When it's 3 people at the same age, I have a friend who has 5 sisters with breast cancer, and they don't carry any gene, and the mother didn't have it, and the grandmother didn't have it. So they were probably exposed to some carcinogen when they were all kids, and so they all get breast cancer. So one of the big things we're looking for in the Army of Women, and one of the areas that I'm trying to do research on, is to find the cause of breast cancer. We do a lot on finding the cure, but the cure has a lot of side effects. And if we could just have a cause and do, like we do for cancer of the cervix, have a vaccine, we could put all the rest of this out of business, and it would be terrific. I'm sure we could find other places, other things to do, and other places to spend our money.
Right.
So it's these kinds of hints of why do 3 people in one family have 3 different kinds that we need to study in the Army of Women and in our soon coming Health of Women study. So we encourage you to please Get involved. So, and send your questions in, because we don't want to just ask the questions that we think of. We want to ask the questions that you've noticed or that you think of that seem to be important.
Yeah. We need to also highlight that that not only do we need to do research and continue research on invasive breast cancer, but we need to do more research on DCIS, on pre-invasive disease.
Absolutely.
And then even on atypical ductal hyperplasias, we look at this, the molecular changes that occur. There's something real going on.
Yeah.
There's going to be an explanation, and again, we need to find that explanation in order to be able to now ultimately prevent and eradicate breast cancer.
But we need to figure out what the key characteristics are, because it's like looking at kids in high school and trying to pick out who's going to grow up to be a criminal. You know, they all dress funny and they all talk funny. And I have a kid just out of college, but not all of them turn out to be criminals. Some of them clean up their act and become hedge fund salesmen. So, you know, with atypical hyperplasia, some of those may well go on to become cancer, but we need to figure out which ones, so that we're not over-treating everybody just to prevent a few, but figuring it out in terms of that. Now, we have a couple more questions. This is one that I think is particularly important. Lorna Boucher, what happens when you're done all your treatments, you're starting to feel somewhat like yourself again? Where do you go from here? I know there are checkups to make sure things are okay, but you always thinking it will come back. Want to know, where do I go from here? The chemo's left me with some problems, but besides that, what happens next? And this is a great question, because when you're treating the cancer, you feel like at least something's happening and it's being done. But when it's all over with, you're sort of like, now what? And your friends are sort of not thinking about cancer so much anymore, and so they're not around, and it's a very scary time. And I think support groups can be really important at this point, other people who have been through it. This is where the neighborhood really is something you can work on. Exercise, as we said, will not only decrease getting it, but decrease recurrences from breast cancer. Watching your weight. A lot of women gain weight on chemo. It can be a side effect of some of the hormones. So exercising and trying to lose weight so that you're a healthy weight can be very important in preventing recurrences. And then stress reduction. You know, I used to poo-poo that and say, oh yeah, stress can't cause mutated cells. But then we found out that it changes the neighborhood. Yeah. I saw a woman the other day in the farmer's market came up to me and said, you know, I had breast cancer 20 years ago, I had a mastectomy, and this year it came back again in my scar. How could that be? And I said, well, what's been going on in your life? Oh, I had the most stressful year of my life. My mother got Alzheimer's. We had to move her out of her house into a home. I had to quit my job because she lives halfway across the country. I've never had so much stress before. And I said, well, that's what it was. Those cells were in that scar asleep for 20 years. And then they woke up with the stress. Right. And so we can't eliminate stress in our lives. It's going to come one way or another, but we can learn techniques to help us deal with it, whether it's exercise or meditation or a support group. So I think the next thing for Lorna has to be get together, find a group, a local group, or if there's nobody around that you like, go online and find an online group that you can support each other, exercise, watch your diet, watch your weight. Those are the kinds of things that are also going to reduce your chances of recurrence. So now there's things that you can do that will actually be helpful. Another question is, my mom had breast cancer in 2007. She's the only one in our entire family to have had it. My question is, when should I have a mammogram? I'm 37 now. I'm confused since it doesn't run in our family, but mom had it. Mm-hmm. You don't say how old your mother was when she had it, but you know, just having a mother with breast cancer does not increase your risk that much. And so I would have a first mammogram around 40, see what the breast looks like. If your breast is very fatty, it's one of the first times in life you want to be fatty. But that means you have a lower risk of getting breast cancer. If it's more dense, you have a higher risk, and maybe you should continue getting them in your 40s. And that's something you should look at with your doctor in order to get an answer on that. But we don't have, it's not one size fits all even for mammography screening. You know, and we're really starting to figure out how can we pick out who's got to be screened more often, who's got to be screened less often, and what should we, you know, what should we do, because it's going to find things, and the radiation risk is not zero. Another woman, Dawn Michelle Harrington, Flores, had bloody nipple discharge in her right breast 2 years ago, and it was DCIS. She had an 18-month-old at the time. She didn't want radiation, so she had a mastectomy, and didn't show up on mammogram or ultrasound. And she's been having MRIs. Should she continue with those? She's 37. Yes, she probably should continue with them, but it also brings up another issue, which is that there's a higher risk of breast cancer while you're pregnant, and for the next 10 years, slowly going down. So, and then the fact that you were pregnant means you're at lower risk. So the fact that she found it when she had an 18-month-old is right sort of on target. And what happens is the breast has to go from just sort of hanging out to be able to make blood into milk, to be a milk factory, which is really pretty magical when you think about it. But there's lots of growth factors, there's lots of hormones, there's a whole lot of stuff going on in there. So if you have a mutated cell, you are changing the neighborhood. There's a big uproar going on in your neighborhood, and you're much more likely to end up with cancer. And then after you've been pregnant and after you've breastfed, then your breasts have to reprogram so that they can get ready for the next kid. And that also increases the risk of breast cancer. So this notion that we have that somehow, we've said all along that that being pregnant early reduces your risk, and it does, but only in hindsight. While you're pregnant, if there's something abnormal, you need to get it checked out. Let's see, I think we have a few more questions. There's a question about taking tamoxifen for benign disease. You can do that for cysts and masses. The problem is, however, that it also has side effects. It causes uterine cancer, can cause cataracts. These side effects aren't that common, and if you have cancer and it's going to help deal with it, that's worth it. But for benign disease, I probably wouldn't take tamoxifen. Let's see, somebody whose BRCA1 was negative, their BRCA2 is undetermined. 2 mammograms showed a shadow, and then they found a lump, and she's going to have on Friday an MRI and ultrasound, which sounds right. She takes progesterone for PCOS, and has a strong family history. Could the progesterone be causing it? You know, that's a good question. We know with postmenopausal women, if you have both estrogen and progesterone, you have a higher risk. That the progesterone seems to be worse for the breast than the estrogen. But for premenopausal women, it really hasn't been well studied, so I don't think we know the answer. And the question is, you know, how much do you need it for the symptoms of the PCOS, and that's something you need to look at. But the best thing is exactly what you're doing, having the MRI, figuring out what's going on in the shadow, whether it's really anything or not. Will answer it. So I've noticed in the questions some of you are asking whether you can get a copy of this. Absolutely. We're going to put this up on the website so that you will be able to both see the slides and hear it. We've been, as you've noticed, videotaping it. We'll have that up on the website as well. So it's available for you to look at maybe with a little more calm. And if you come up with other questions, we're happy to answer them for you, and you can get them to us. And I think we've done just about all of them. So at this point, I want to thank you all for joining us for Breast Cancer 101. We, as those of you in the Army of Women know, we do these webinars routinely. We will be having webinars also with the results of some of the studies some of you participated with. So please keep tracking along with the Army of Women, and you'll know when you can hear us.
And Susan, how big is the Army? And it's getting bigger every day.
The Army's at least 356,000 women right now, and you can sign up at armyofwomen.org. Thank you all very much, and have a great day. And thank you, Steve, for joining me.
Thank you.